Adenosine is an antidysrhythmic used to treat paroxysmal SVT. It's a nucleoside that binds to type 1 or A1 receptors around the AV node. It causes hyperpolarization of the cells, so creates like a transient block of signals through the AV node. So stops those reentrant making it through the AV node and hoping to restore it to sinus rhythm. So we give it for SVT above 150 beats per minute in those aged greater than 12 years. We give it for mild compromise if they have had it in the past and it's successfully reverted, or for moderate compromise. For severe compromise, you're looking at a synchronized cardioversion. Of course, before you decide on which of these treatments you're going to do, you need to rule out underlying causes of the SVT. The most important would be infection. So with your history taking and taking a full set of baselines, making sure that it's not something else causing that tachycardia. Our contraindications for adenosine are known severe allergy, a heart transplantation without an internal pacemaker, a previous second or third degree heart block without an internal pacemaker, and sick sinus syndrome without an internal pacemaker. So in those patients, you can precipitate a serious heart block that doesn't self-revert. Our cautions are current bronchospasm from asthma or COPD, as it can cause a worsening of that bronchospasm. And another caution is Wolff-Parkinson-White syndrome currently in a fast AF, as that can precipitate VF. So you want to be really sure that this is an SVT, not an atrial fibrillation. The way that we give it is, well, the preparation that comes in is 6 milligrams in 2 mils. So our first dose is 6 milligrams. Once you've drawn that up, you draw it up undiluted in your nicely labelled syringe. And you also want 20 mils of sodium chloride for a fast flush. You want to have it in a large bore IV in a large vein, so an ACF with a, preferably an 18 in. The reason for this is that the half-life or the duration effect is only 10 to 20 seconds, as it's rapidly metabolized by red blood cells. And if you don't get it to the heart in a big bolus, then it will be metabolized before its effects can actually work. So you want to get it in as quickly as you can. So make sure you got yourself all sorted. And you're going to go a fast bolus followed by a rapid flush. Before you do that, you do want to warn your patient that they may feel awful for a few seconds. So it will cause some kind of sinus pause generally, and a lowered cardiac output, so they will feel that kind of impending doom. They'll feel very unwell. So warn them about that and talk them through it as it's happening. Attempt to capture the reversion on your ECG is ideal. So once it's gone in, you'll know really quickly whether it's worked or not. If it hasn't worked, you can repeat the dose and go 12 milligrams, so 2 of the 6 milligrams in 2 mils. Try that again. If that doesn't work, then you need to look at other options or look at transporting. Obviously, you're going to get a 12 lead before and after, and make sure you get a full set of baselines afterwards.